Good evening, everyone, and welcome to yet again another Better Billing webinar series due to our overwhelming demand. Our first session for this series is mental health changes in bulk billing and bulk billing incentives. What do I need to know for my practice? I'm Helene and I'm Workforce Development Coordinator here at Westwick PHN, and I'm working alongside Jade, who also works here. I'll be facilitating this evening. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience and ongoing places that First People hold in our communities. We pay our respect to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for the First Nations people and organisations. A little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel, and the link there is up on the screen. You can see our upcoming events also on the link and register them via our website. You may have seen that we've recently launched our new Learn Network monthly newsletter. This is the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code now on the screen. Editions are released on the first Tuesday of each month. There's also a link in the chat where you can submit your education and training requests for inclusion for our 2026 calendar. Just a reminder about Health Pathways, our free online resource with localised clinical and referral information for health practitioners. A certificate will be emailed to you all, so if you could take the time to check that your full name is displayed accurately on the screen. If not, or you're not sure, just type it in again so that we can make sure we get that certificate to you. This event will be recorded, so just keep yourself on mute unless you would like to ask a question. We do encourage interactivity and discussion, so feel free to type your question in the chat box. I can answer that on your behalf at the end of the session in Q&A time, or you may be able to take yourself off mute then and ask your question. Feedback is important, so please take the time to fill that survey in at the end of the webinar. There's a link there, and there'll be a link at the end of the thing. So let's get straight into it with our presenter once again, Dr. Ashley Van Leeuwestyn. Thanks, Ash.
Thanks, Helene. Thanks, guys. So let me just share my screen one moment. Perfect. Okay, so for those of you who may be tuning in for the first time in any of my webinars, I'm Ash Van Leeuwestyn. I'm a GP that's based in New South Wales. And literally about 14 days ago, I have finished my training and I'm officially a GP, completed my training now. So I also own and created BetterBilling, which is an online platform that helps GPs, practice managers, and nursing staff in general practice learn more about billing, how to do it effectively, and also being able to teach yourself on the go through our online education platform. Now, obviously, I've worked with this PHN quite a lot, and this is talk number 8 for me. I feel like it might have been only in the last 12, 18 months. And so this talk is the hot topic at the moment, which is obviously the changes in the mental health care plans, but also our bulk billing incentives and what we need to know, and also how to figure out what our practice is going to benefit from this. So as always, I always encourage chat questions during the presentation, and if something comes up a lot, I will jump on. But at the end, we normally leave the Q&As for me to have a look at. So we'll get started. Okay, so the first bit that we'll be talking about tonight is the mental health care changes, and there's a few different things that have happened. One of the biggest things is the linking with My Medicare. So this is starting to happen a lot during our MBS items. Is that this new link to My Medicare? And if you haven't seen my talk previously about My Medicare, I recommend jumping on the YouTube channel, having a bit of a read about it. So this now means that patients can only access a mental health care plan through their regular GP. GP that they either identify through signing a My Medicare form within your practice, or if they refuse to be a participant in My Medicare, then that normally means that this is the GP that they identify as their regular GP. Um, if for some reason someone is to take on a new patient and they are not registered in My Medicare for them, but they have and they are not signed elsewhere, they can complete the mental health care plan. We also have some removed items in the mental health space. There is some, we'll talk a little bit about existing plans validity. So the fact that existing plans are still able to access psychological support for those patients. The allied health numbers have remained unchanged. So our allied health colleagues have no changes in the mental health care space from a billing point of view. And also a little bit about what to do from here around reviews. And now that a lot of us have lost that review revenue income. So let's have a look here. And what you'll be able to see here is what we've currently got. And what we can see here is we've got the table, which shows you've got some item numbers of mental health skills training and those without mental health skills training. And normally I really recommend that every GP is having a look at mental health skills training. The reason why, for obvious reasons, is the rebate is better. So it's better for your patient. If you're a bulk billing service, it's also better for your practice. There's also some decent education to come out of the mental health skills training, and it's free, it's online. Yes, it might take you a couple of hours, but it does make a substantial difference in the long run. What we'll be able to sort of see here is these are the mental health care item numbers now. So as of now, we have lost the mental health care plan review, it's 2712, and the mental health consult, which is 2713. So if you were previously using those numbers, they are no longer going to be able to be effective. The other thing to mention here is around our telehealth item numbers. And the telehealth item numbers, or telehealth rules have tightened. So previously, especially in COVID times, there was a large amount of flexibility in whether the patient had an established relationship with the practitioner to be able to access more emergent telehealth item numbers. However, those rules have now tightened with the rest of the telehealth item numbers. So those accessing mental health were able to avoid the existing relationship rule, but now that does have to fit the existing relationship rule for patients, regular GP, registered with My Medicare, and have seen them at least twice twice in 12 months for My Medicare, and at least once in the year to be able to see them on a telehealth platform. So another thing about My Medicare. So where is the country at in terms of My Medicare at the moment? So in terms of number of practices that are registered, we have about 80% of practices in Australia that are registered with My Medicare, and only about 1 in 10 patients are actually registered with their provider. So obviously we have our practices getting ready, not wanting to miss any incentives, missing out on item numbers such as care plans now, as well as the mental health care plans, but only 1/10 of patients are actually being registered. We might start to see that number obviously increase as a lot of our item numbers are now reliant on it, but just something to sort of have a look at and see where your practice is sitting. So other points in terms of the mental health care plan, so existing mental health care plans. So in terms of referrals that are made before the 1st of November, they will remain valid for the remaining sessions under that referral, even after the change date. So if your patient has already accessed their full 10 sessions in a year, and they are, if they haven't accessed their full 10 sessions in a year, but the referral was completed prior to these changes, they'll still be able to access those referrals with their psychologist. Nothing will change for the patient with existing referrals. Allied health item numbers and the focused psychological strategies for those GPs completing that service. The billing continues as completely normal. I won't go into their component of billing tonight, but for this sake, it's good to know that it's completely the same. So for a lot of us, we kind of say where to now. And the reason why is about the loss of the mental health care reviews and the mental health care consults. So this here is a little bit of a summary of our public data that's available for how many item numbers are billed each year through Medicare. You can divide it by state, but in this case, I've just popped it all into for the entire of Australia. You'll be able to see here that approximately 1.2 million mental health care plans were created and billed for within 2024 and 2025. So these are your item numbers here that create mental health care plans. So 2715 and 2712. And then what we can see here, there's about 591,000 mental health care plan reviews were billed in that same time. So we're getting about 50% of our patients are coming in for their mental health review or are just being billed by their GP for a review, and the other half are not. And as a result, we've ended up losing the mental health care plan review item number, so the 2712. You can see here as well that we've had just over 1 million mental health care consults that's been billed by GPs for the 2713 in that same financial year of 24-25. So what does this actually mean? So if we have a look at our GPs in Australia and seeing what the average GP is doing, it's working out to be about 18 care plans, mental health care plans per year. And that you might either identify as one of those, or you may identify someone who is doing substantially more mental health care plans, such as that. If you fit the average mold in this case, that's about $1,500 worth of billing per year being lost if you were someone who actively completed a lot of care plan reviews or mental health care consultations, and splitting the item number often with general attendances. However, if you are some of our better billing GPs who are on our subscription program and are talking about where their losses are coming from, that can be up to approximately $10,000 worth of billing per year that's being lost. And so we're starting to have to get a little bit smarter around our billing and looking for other opportunities around co-billing, which is what my next talk will be on in 2 weeks. However, having a think about it, if you are interested, have a look at your own statistics, see where you sit and what the loss looks like for you, especially losing the care plan reviews. So having a look at now what our old care plan, mental health care plans look like, and now what the new ones, the new workflow looks like. So previously you would have completed the mental health care plan, and then what you could do is you were able to do a review in the first month, doing a 2712, and then you would be able to review every 3 months after that. That was the old one. There were also a lot of co-billing opportunities in the 2712. So you were able to bill this with a lot of item numbers, so general attendances, care plans, other health assessments, medication reviews at the same time, etc. So there was a very flexible number to be able to be used. The new mental health care plan workflow, however, is when a care plan is created, you are able to review as needed and using general attendance items such as 23, 36, 44, or any other equivalent item numbers in terms of video and phone. So there are no specific number of times and no specific amount of time that you need to wait to complete your review. The review now is just done as required via general attendance. A little note as well before I jump into into our incentives, our bulk billing incentives, is a note for women's health and for those GPs who are doing a lot of women's health. And there is actually a really great increase in our rebates for those women accessing long-acting reversible contraception or LARCs, and that's particularly the Implanon and the IUDs. So we've got 4 existing item numbers. The 3 that are listed here are the ones relevant to GPs. Another one is under general anesthetic. If you're someone who does that, then have a look into my site. That'll be there's a blog post that's available about it. But what we can see is a very decent steep in terms of our funds from Medicare for being able to complete these services to patients. So the IUD, Implanon insertion and removal. There is also a LARC bulk billing loading item number 35501. which is a 40% increase of the fee for any of the item numbers that have been billed, that are bulk billed for patients. I am a GP that is now offering bulk billing IUDs and implanons to my patients, and that is because of the LARC bulk billing loading fee, but being able to do so. And so I really recommend having a look and being able to see if you can do something similar. You will also be able to see that we do have a menopause talk on towards the end of this year. We'll be going into this a little bit more detail around billing. There is also a really great change with the implanons for those who are doing implanons quite regularly. Medicare would sort of say that we could only remove an implanon and not bill for the insertion of another one at the same time. However, that has now changed and that rule has been removed. So you can bill a 14206 and a 30062, the implanon insertion and removal at the same time. And being able to bulk bill both items with a 40% fee, again, makes it bulk billable for a lot of patients. So let's talk a little bit in terms of the bulk billing incentives. So these are the ones that are available from November, and this is where the bulk of tonight will be around. So firstly, I'm going to talk about expanding the current bulk billing incentive and what that means. And then the second is introducing the bulk billing practice incentive program and helping you guys figure out how you can decide whether you are a practice that would benefit from this or not. So expanding the bulk billing incentives, and this is actually a really good incentive that we've been able to do. So prior to November, if we were bulk billing a patient that was under 16 and a concession card and a concession card holder as well, we would be able to claim the triple bulk billing incentive. So we'll get to those in the next slide of which one's relevant to your area. However, after November, all eligible patients, all patients are eligible who are bulk billed for this triple incentive. So if you previously had patients that you would have liked to have been able to bulk bill for the triple incentive, they didn't have a healthcare card or they just turned 17, whatever that might be, now those patients are able to be bulk billed with the incentive as well. So having a look at what the triple bulk billing incentive is versus the normal bulk billing incentive. So the triple bulk billing incentive is the item numbers which will come up next, but they are only applicable for certain consultations. Now they are available for face-to-face consultations from level B to level E. So those are the ones from at least 6 minutes long, which is level B. They are also available for phone or video level B, which is another option as well. And they're also available for video consults for level C and level E if the patient is My Medicare registered. So only those ones would triple bulk billing incentives be available. In terms of your triple bulk billing incentive or even the other bulk billing incentive, it all really depends on the rural location of the practice or the location. And so we have location areas 1 to 7, 1 being metropolitan areas and 7 being very rural and remote areas. And obviously, a lot of you now would already know where your practices sit, but if you're unsure, have a look online and see what category you are that you can find on the government website based off the location of your practice. Now, in terms of the telehealth rule location, and if someone sort of says, my practice is in MM2, but my patient is in MM3, what bulk billing incentive am I able to have? And it is based off the provider number's practice location and not the patient's location. So because you might be seeing a patient who has somehow moved out recently into an area that's very rural, but is still contacting you from your MM1 practice, you are not able to claim the bulk billing incentives because they are currently rural. In terms of the normal bulk billing incentives, these are your baseline incentives that are available for level A consultations, level C and level E video consults when patients are not My Medicare registered, and all of the other eligible services like chronic care or your GP CCMPs, mental health care plan, eating disorder care plans, health assessments, minor procedures, etc. And again, the same principle applies. Depending on how rural the practice is, it depends on the bulk billing incentive that's offered. So having a look here at this table, this is where we're having a look at those incentives. Now you see, what you'll be able to see is we've got here the top 3 rows are the bulk billing incentives that attract a triple fee. And these are the triple bulk billing incentives that have level B, C, D, or E, that's face to face, phone or video level B, level C, D, or and E, if the and they're not My Medicare registered, if you can see those ones there. Now, the bottom one is the all other eligible services that are covered, not covered from above. Now, what you'll be able to see at the top is all of the levels. So if we have a look at MM1, we can see those differences there. And then we can see MM1 next to, or in terms of the third column here, which is a service that's provided after hours into a region that is MM2 to 7. And this is actually specifically for services that are done after hours where you are able to see patients for in terms of an after hours consultation. So if you were going to your RACF after hours, if you're doing home visits, etc. And you'll be able to see here your bulk billing incentive for will also be different during that time for all other eligible services that might happen. So let's have a little bit of a talk at the point now of around the bulk billing practice incentive payment. And this is a very hot topic because a lot of practices are trying to figure out whether this will work for them long term going into making the decision to be 100% bulk billing. And for some practices, this is a really easy decision, and they were already practically built billing 100% of their patients, their rural centres, etc., that are bulk billing their patients because their community can't afford to be any different. So having a think about this, for a lot of us GPs, I've done the maths myself. I've been able to use a GP that works with Better Billing information for tonight for me being able to show you how you can calculate your own and see about whether this is something for your practice or not. So the 3 takeaway points for bulk billing practice incentive, or the PIP payment, is you you get a 12.5% fee or incentive, that I should say, on eligible items. So this is not every single item that is bulk billed through your practice. This is eligible items, which we'll go through. The incentive payment, or the PIP, is split evenly between the GP and the clinic. It's very clear about that. And it can't really be split elsewhere. But it needs to be 50-50 between both the GP and the clinic. And it is paid quarterly in terms of your financial quarters with Medicare. So having a look, I've created a bit of a table to help us understand if your practice can be eligible for the bulk billing PIP program, or whether they cannot be. So having a look first in terms of who is eligible for general practices with a fixed address, fixed site, so your normal general practice locations, mobile practices, outreach practices, sole providers or independent GPs working on their own, an Aboriginal community controlled health service, or an AMS, an Aboriginal medical service, or an after hours GP service. People who are not eligible for the bulk billing PIP is Medicare's urgent care clinics. So they cannot, or if there's any service that's not providing continuous GP primary care, like episodic or acute care only models. So they are not eligible for this. In terms of your My Medicare status, the practice itself needs to be registered for My Medicare. So the banking detail needs to be entered for all of the providers, however works in your practice. And new participants can use accreditation exemptions if they've not previously been accredited. So if practices are struggling trying to get their My Medicare status, they don't fit that process, they're trying to decide whether they're going to do it or not, then you are able to use an accreditation exemption to be able to be eligible for the bulk billing PIP immediately if you fit that criteria. In terms of who is not eligible in the My Medicare status, if your practice is not registered with My Medicare and they do not fit an accreditation exemption, if your accreditation has lapsed and you previously were accredited, or if you have not linked providers in your organisation register on PRODA. Then in terms of bulk billing requirements, this is where all eligible MBS services, so these services specifically, need to be bulk billed for all Medicare eligible patients, including your DVA patients. However, if a practice or a provider privately bills or charges a gap for any of the eligible items, that makes you not eligible for your PIP. So this means if you have one GP who decides that they are going to charge privately a gap, your practice will not be able to access the PIP during that quarter. If there has been any failure to bulk bill across all eligible services or any patients with Medicare eligible patients, you again will not be able to have access to the PIP. In terms of the providers or GPs, it is only for this PIP is only for GPs, non-VR GPs, and VR GPs, GP registrars or locums, which also locums need to have their provider linked in the bulk billing PIP site as well. This is not for non-GP specialists, non-GP providers. It is not for GPs not willing to participate in My Medicare or without valid provider numbers. Patient registration. So patients do not need to be registered in My Medicare for your practice to be eligible for this PIP. Terms of your practice structure, there's another thing to mention about this here, and that is about making sure that your practice is correctly registered in the organisation register. All providers as well need to have that organisation site registered for their PIP. So all of your providers need to be registered there, and the practice needs to be registered there. Co-located practices that operate independently can have this going as well. So that's if your practice has a pharmacy inside or it has an urgent care clinic that's also happening, but it's got different signage, etc. However, if you have a shared premises without a very clear separation of your business or clear separation of signage, then you're unable to access the bulk billing PIP. If there's practices with inaccurate or incomplete organisation register data, then you are unable to have that as well. In terms of your practices being sold, there's been relocation, there's been new owners, etc., then you will not be able to access that PIP as well. Now, in terms of signage and promotion, it's very clear in the guidelines around what they recommend or what they expect for people who are fitting the bulk billing incentive. And you would have seen a lot of signage coming around from other practices around saying, I'm a bulk billing practice now, I'm 100% bulk billing. And that's about being accessing their PIP. So you need to be registered on Health Direct's National Health Service Directory as a bulk billing practice. And you also need to display that you have that Medicare bulk billing practice signage on site where applicable. If you do not meet your signage requirement and you're not on Health Direct's directory and you have repeated non-compliance, you can actually be excluded from the PIP and not be able to access that. In terms of other administrative or legal issues, etc., there needs to be all compliance reporting obligations under the MBS My Medicare and the bulk billing PIP. So the practice cannot be under the investigation for fraud or anything very concerning. Another thing is the organisation appears on a non-participating institution list for the National Redress Scheme, cannot also access this bulk billing PIP. And also if they are providing false or misleading information, if they're under investigation for fraud or there's been any sort of breaches. Okay. So what are the eligible items? So what item numbers will actually generate this 12.5% increase PIP? So GP consultations. So your level A, level B, level C, level D, level E. Your sexual health and reproductive telehealth item numbers as well. Your health assessment items, so the ones that fit the 701 to 707 time-based health assessments, your Aboriginal and Torres Strait Islander health assessment 715, your heart health assessment 699, and your menopause health assessment 695. Mental health care plans will as well. If you are a GP that provides focused psychological strategies, you will also be under that eligible item as well for being bulk billed. The chronic disease and complex care, so GP CCMPs are also able to do it and their reviews. case conferencing, and medication reviews, as well as residential aged care medication reviews. If you're providing after hours services in non-urgent or urgent after hours services, they also are an eligible item that would need to be bulk billed as well. And GP flag fall items, which support us accessing in terms of after hours, or no, in terms of RACF or aged care, as well as providing home visits for those people who may need them. So the question is, should I change to be a bulk billing PIP practice? And I mean, there's no real easy answer, but this is one of the first things that most people have been able to access. And there's a website by the Australian government which helps you estimate your payments from upcoming changes to the bulk billing incentives in general practice. And a lot of people have put this in for themselves and being able to see it. And this is what I'm going to run through for you. So this is if you don't enter any numbers, which is actually based off the average full-time GP in Australia. And you can see here the estimated payment in the financial year, 353,000. And then what you can see is the estimated payment if you didn't change, being mixed billing, and you just offered some bulk billing to those people who you wish to, and get the triple incentive from that. So you can see there's about an extra $20,000 per year that's being able to access for GPs who are now using the bulk billing incentives, which are better than previously. Now, this is what they've also mentioned is, if your practice participates in the PIP, what would the difference look like? And these are just numbers that are based off the average GP. So this is not anything else. But let's have a look at it a little bit more specifically. Now, if you go down into the bottom of the calculator, what it actually shows you is this screen. And this can actually be quite confusing. But what it shows you is both the savings to your patients, which is this increase, this $47,000 per year is being saved to your patients if you move to 100% bulk billing, versus the change to payments from bulk billing all eligible patients for all services and participating in your bulk billing PIP. So you can see here it's saying that this is the added fee that would be available to GPs, an individual GP that fits the full-time practice load. Now, when I did have a look at this, I had a little bit of is too good to be true situation, and decided to calculate this for a GP that I work with. It was happy for me to keep her anonymous, but be able to use what her billings have been looking like. So I had a little bit of a look at this calculator and put Marnie in mind. Marnie's obviously a fake name, but Marnie's a 38-year-old GP. She works 3 days per week, sometimes 3.5, depending on if she's doing extra things from home. She's currently mixed billing, and at the moment, she probably bulk bills 74% of the time. So she's a better billing GP, and she's very good at her chronic disease management, and she's billing about chronic disease item numbers at least 40 to 50% of the time. So she's very good at her chronic disease item numbers. But this is what hers would look like. So if I put her numbers in, based off her 3 days per week, what her current income was looking like, and we're having a look here now where we're at, which is the 416,000 each year, being able to access in terms of her take home pay. So you'll be able to see here what her share versus the 30% that she shares with her practice, and what that looks like for those who are accessing the bulk billing incentives, because you've now got these for patients that you previously weren't being able to do. And then having a look here in terms of her PIP, it sort of provided her with the practice and her a little bit of extra money. But what we will see is the practice itself tends to benefit predominantly from the PIP. So let's have a look at the actual calculations and the calculated problems. So with this calculator, it doesn't really take into account revenue that you create from procedures and billings that don't attract the bulk billing PIP. So it does have other, but it does not include procedures or anything that might be quite big ticket item numbers for those who are doing it. For those who are currently doing a lot of workers' compensation, it doesn't have an area for that. It also does not take into an account any financial gains if you are particularly great at women's health and are doing a lot of implant-on and IUD insertions. Doesn't take that into account. It also does not take into account your loss of 2712 and 2713 if you were previously using that a lot before. And also, if you put in rough estimates, it's not giving good true figures. So we did it together. It was long, but we did it. And so what we had a look at was Marnie's quarter. So this is Marnie's last quarter, and her total fees here were 125,000. So this is roughly, but this is generally what the situation was. In terms of her breakdown, she billed approximately $30,000 in private fees. She billed 90,000 dollars in about Medicare fees. She did a $1,600 in other fees, and which is for her workers' compensation. And then the other was $3,000 in DBA fees. Now, what we were able to actually do was work backwards and isolate her eligible item numbers. So you're able to pull these reports from BP. The report I would be pulling is Service Export. What you'll be able to do there is see which Medicare item numbers, the eligible item numbers that you're billing, and convert all of your private ones into Medicare only fees. Now, when we were being able to do that, what we actually seen was we had her Medicare eligible fees, Medicare fees on eligible items. So these are the ones that attract the PIP. So 86,000 out of her 125,000 were eligible items. So those item numbers are the only one that would generate the PIP. This one here is her bulk billing items and private fees. So this is bulk billed only and for private fees that are non-PIP related. So that might be procedural related things such as private IUDs, private skin cancer, etc., which she does a combination of both. So being able to have a look here, what we would see on the eligible fee items is the 12.5% PIP. So there would be 5,000 bonus PIP in this quarter to the practice and about 5,000 bonus PIP to the GP. So seeing for the GP, her total fees were actually reduced by $10,000 per quarter by going completely bulk billed and taking on the PIP. Now, Marnie's total outcome, like I was saying, is a loss of about $10,000 per quarter by going to the bulk billing PIP or going 100% bulk billing incentive. Marnie's practice owner, however, there was a difference. And with Marnie's practice owner, there's a 70-30 split. Now, with no bulk billing practice incentive, the practice owner's service fees during that time was $37,500 for the practice. But going fully bulk billing practice incentive and going as a fully 100% bulk billing practice, the practice share of the PIP was 5,420, with their normal 30% fee service fee of 34,000. It did work out to be about $2,000 per quarter for the practice to gain in terms of what they would have previously got if Marnie was not a bulk billing practice. So having a look at all of that, let's have a look at the pros and the cons and have a decision for yourself. So pros of going fully bulk billing is that it's a great PIP that provides 50-50 support fee in terms of the practice and the GP. It's very clear. We know what we're getting. There's less FPOS, there's less billing disputes, there's less outstanding private fees if that's a problem. It also removes barriers for a very large number of patients who want to seek care. And so that's one particularly helpful thing. There's also more visibility of your practice being linked with Health Direct. Now, in terms of cons of going full bulk billing, this is where you're kind of looking at you're losing your private fee margin. And quite often for individual practitioners, the 12.5% PIP does not normally replace the income that someone who would be a traditional full-time GP working in a mixed billing practice would generate. They also may need higher patients load to compensate for their loss of fees, which is something that, depending on your practice, whether you're able to increase your number of appointments per day, that might be an option. But if not, this is not always the best. Other thing is there is zero tolerance for errors. So in terms of the bulk billing practice incentive program and the information that's found online in the PDF, they are very clear about not having any private fees during that time. If you do by accident give a private fee to a patient and you've realized, or there's been a new reception staff member who's done it by accident, you can provide the Medicare organization with a reason as to what's happened. We're so sorry. We won't do this again. We've refunded the money. We've processed it as bulk billing, whatever that might be. However, you really need to make sure that the entire practice is going bulk billing. It also needs to fit the signage and the listing requirements, and that's also very specific in the handbook, is needing to fit and have those signs on display. So, should I go fully bulk billing? The answer is use a calculator yourself. Go backwards, do the numbers yourself. The calculator might be helpful online if you're predominantly just doing the item numbers that are listed. But if you're doing mixed care with lots of procedures or insertions, etc., go back and have a look at your numbers, because it may not be a true representation of what the calculator is being able to show. Um, for those who I have worked with that are fully bulk billing, they are already a bulk billing a very large portion of their patients, and this works for them. If they're already doing high volume and shorter consult models, and or if they're already rural and remote and their bulk billing incentives are helping them keep their doors open, they're practices who will also benefit from going and being registered for the bulk billing PIP. So this is the end of my talk. So we've got a fair bit of time to be able to have a chat around what questions we might have. So let me just pop up the Helene and Jade. I'm just going to open up the chat right now. Okay, question about the 35503 insertion of an IUD. Is the schedule fee for a GP 183.60 or 215.95? Can the GP claim 35501 with the 35503 item number? Yes. Okay. So your fee, if you're having a look, I would have to bring it up for you in just a moment. In terms of your fee for the IUD. So say you're billing for the IUD insertion, so that's 35503, and then you're billing the long acting and you've bulk billed it. Then you can claim the 35501, which is the 4% loading, 40% loading fee that comes with bulk billing a long acting contraception. You can only bill the long acting contraception incentive or loading fee if you have fully bulk billed the entire that consultation and the insertion component of the procedure. So, in terms of can you claim both item numbers at the same time? Yes, absolutely. So, in terms of the current MBS schedule, when you are looking at that, that's when you might have a look and you'll see there's a 100% fee, an 85% fee, and a 75% fee. So, the 100% fee is for consultations in general practice. The 85% fee is for procedures that happen outside of a hospital environment. So, for GPs, that is the 85% of procedural fees. So hopefully that answers that question for you. Are there any questions from anybody else? Hello, yes, we are a medical and dental clinic in one entity. To be eligible for bulk billing PIP, do we need to have separate signage and separate site organisation register in PRODA? That is a good question. So it is very clear that in terms of the bulk billing incentive, I would be making sure that you definitely had very clear separate signage and very clear in terms of making sure that this part is a 100% Medicare bulk billing incentive location, and the dental clinic was run completely separately. In terms of separate site organisation registrations in PRODA, I am not particularly sure because I never run a dental practice, but I would be just checking to make sure that you are one would be listed medical, one would be listed dental, etc. But if not, have a look specifically on PRODA, and if not, there is an email that you can email with specific questions around the bulk billing PIP and what you would have to do. But in terms of the signage and making it very clear that you are 100% bulk billing, that is a very important part of the PIP. So yes, I would be investing in making sure there's clear signage of that. Any other questions? Okay, well, look, while I've got some in terms of if you're interested in what Better Billing does, we do have online courses. You're very welcome to have a look online. We also do access template. We have a large number of templates. So we do have a free resource hub, which is available for anybody without a subscription, with a subscription. And that is about being able to access your any sort of templates that you might be using, whether they are AI, letter writer, etc. There's a whole resource on there, and you're very welcome to go right ahead and take anything off there that you like. And obviously, for webinars, you'll definitely see me in the next few weeks before Christmas, before we do it. Oh, I've got another question. Do you get a sense of where the tipping point would be in terms of bulk billing percentage currently to make switching the to universal bulk billing worthwhile? Probably an unanswerable question, I know. It's very hard. Yes. I mean, it really depends on the practice and also the practitioner, because for a lot of us, if we're doing a large portion of procedures, etc., that are generating quite a large amount of our income. So, thinking more than, saying more than a quarter or so, it's really not particularly worthwhile. But if you were, say, a GP doing a very large amount of general consultations, and seeing your patients' care plans, RACF, etc., and wasn't particularly procedural, I would say it would be quite profitable. However, that also I'd really recommend that practitioner would probably already be bulk billing a very large portion, or are doing such a very large volume of patients per day to be able to make that quite profitable. I suppose we definitely play with the numbers. I haven't, but definitely something to think about.
Okay, thanks, Ash.
No worries.
Still got a little bit of time if anyone wants to take themselves off mute or quickly type a question in. I'll just take this opportunity. Thank you again, Ash. Always a pleasure to have you on board. And I
Thanks,
think we've got a
guys.
couple more coming before the end of this year. So jump into our events page on the website and you'll check them out. And then we'll have some more coming next year. So pop your evaluation in and any topics you want, and we'll see if we can get them going for you. So I'll now end the webinar for all, and we'll see you next time. Thanks, everyone.
Thanks, guys. Bye.